Good afternoon. Good afternoon, and thank you so much for coming to this special symposium. We're delighted to have you here and joining us on such short notice. My name is Dushanka Kleiman. I'm the Associate Dean for Research and the Principal Associate Dean at the School of Public Health at the University of Maryland in College Park. From the day we first learned about the new coronavirus, less than 2 months ago, it's hard to believe, we've been living in the midst of a whirlwind of daily and hourly and minute-by-minute updates about its impact, its spread, and steps that are being taken to contain it and ultimately prevent it. We're still in the very early stages of the epidemic, and it's a time where we have more questions than answers. So what we've done is design this symposium to provide you with a snapshot in time, and I'm sure there'll be many updates. We acted quickly to put the symposium together because we feel that informing our community and the university is an essential role of an academic institution and a school of public health. We want to thank our colleagues in Student Affairs, the Alumni Association, and Strategic Communications for making it possible for us to join and produce this for you today. We have a saying in public health: the critical work that supports the health and well-being of our nation and our population goes unnoticed until there's an emergency. The safety of our food and water, the support for enhanced lifestyle behaviors, the prevention of infectious diseases, the work we do in hospitals in maintaining and managing chronic diseases, health promotion in schools, maternal and child and infant health, and much, much more. So epidemics like this one capture the national and international attention and concerns, and they shine a light on our public health capacity. These events identify gaps in our response, challenge the capacity of our communities, our nations, and our global coordination. They also raise procedural, social, ethical, and legal issues among local, national, and international governments and agencies. They demand an effective response, coordinated well, constant and clear communication, and collaboration in management and sharing of interventions and the conduct of research. At the very end of January, WHO, the World Health Organization's Health Emergencies Program, declared COVID-19, this outbreak that we're in, a public health emergency of international concern. A few days later, the World Health Organization released a strategic preparedness and response plan for the virus, and the plan includes establishing international coordination and operational support, scaling up country readiness and response operations, and accelerating priority research and innovation. Our School of Public Health faculty members have experience with past epidemics. They're conducting research in areas of relevance to this epidemic, including exploring factors affecting compliance with recommended preventive measures, such as the flu vaccine. In addition, our faculty members are contributing to university, state, national, and international discussions relating to evidence-based practices for public health, emergency preparedness, and response. So today's symposium includes 4 presentations to address several emerging questions. Dr. Don Milton will address what we know about this new coronavirus and how it spreads among us. Dr. Milton is a physician scientist, professor of environmental health at the Maryland Institute of Applied Environmental Health. His studies explore infectious bioaerosols, exhaled breath analysis and development, and he investigates the application of innovative methods for respiratory epidemiology. One of his research projects includes the Catch the Virus study that involves undergraduate research assistants tracking respiratory infections in freshman dorms. He'll be followed by Dr. Hanji Liu, who will provide an overview of the features of the COVID-19 epidemic, with a focus on why it has spread so quickly in China, but not at this time in other countries. Dr. Liu is professor of epidemiology and also chair of the Department of Epidemiology and Biostatistics. He studies social and behavioral aspects of HIV/AIDS in research epidemiology. He's designed and led over 20 HIV-related studies, over half of which have been implemented in China. He also was present in China in 2004 at the time of the SARS outbreak, the severe acute respiratory syndrome. At times of emergencies, especially when confronted with an unknown pathogen, the onslaught of information is extremely overwhelming. I don't know about you, but every minute there's a new piece of information. Often, information is conflicting and continually evolving. Dr. Cynthia Bauer, who's an expert in risk communication and health literacy, will speak about effective risk communication as an antidote to fear, uncertainty, and misinformation. Dr. Bauer is an endowed professor and director of the Horwitz Center for Health Literacy. Prior to joining our School of Public Health in 2017, she worked in multiple senior communication leadership roles within the Centers for Disease Control and Prevention and the Office of the Secretary of the Department of Health and Human Services. She has led numerous national initiatives to define best practices and guidelines in health communication and health literacy, and is the co-creator of the CDC Clear Communication Index. Our last presenter is our Dean, Dr. Boris Lushniak, Professor and Dean. He will conclude the presentations by providing highlights of lessons learned from the 2009 influenza pandemic. Dean Lushniak, a physician with specialties in dermatology and preventive medicine, is a retired Rear Admiral of the United States Public Health Service Commission Corps. During his tenure in the Corps, he served in multiple agencies, including the CDC, the Food and Drug Administration, and the Office of the Secretary, and he served as the FDA Assistant Commissioner of Counterterrorism Policy, the Deputy Surgeon General of the U.S. Public Health Service, and also as the Acting Surgeon General. From January to March in 2015, he commanded the U.S. Public Health Service Monrovia Medical Unit in Liberia, which was the only U.S. government hospital providing care to Ebola patients. We would like to acknowledge that there's an audience joining us, including to all of you wonderful individuals in this room. We're live streaming this event. And we welcome comments from those that are here in person as well as those that are online. So this slide provides you a means in which to submit your questions and then to also go for further information to the university site, where after this session you'll be able to see updates as well. So I'd like to begin with our first presenter, Dr. Don Milton, and we will have each presenter come up, give their presentation, then sit down again, and then after the 4 presentations, we'll open it up for questions. Thank you.
Thank you, Dusaka. It's a pleasure. It's a pleasure to be here this afternoon and to talk with you, and I hope that you find this talk that we're doing today to be useful, give you a better understanding of what's going on, and give you an understanding of what you can do. So what are coronaviruses? We've been hearing that name a lot, as though there were one coronavirus, but actually there are lots of coronaviruses. Practically every living species of animal has a coronavirus or two or three that infect it. Everything from rats and bats to beluga whales have coronaviruses. And these viruses mutate slowly. You may be aware that other RNA viruses, particularly influenza virus, which is an RNA virus, mutates very rapidly, changes from year to year, which is why we have to change the vaccine frequently. Not so much with coronaviruses. They're more stable genetically, but they still seem to come around and people get them one year after another. There are four that people get commonly. They cause common cold-like symptoms, and they have names like OC43 that you see up on the screen. And they've been infecting humans, we think, for hundreds, maybe thousands of years. So they're nothing new. You've all had them before. Our data on antibody levels on people on campus suggests that everybody has lots of antibodies against these because we've all been infected with them before. But there are three that have emerged recently. The first was SARS in 2003. The second was MERS in 2012. And the third is this SARS-CoV, or COVID-19 disease, that emerged in December of 2019. And those are the ones that we're talking about. Now, because the other four that we get all the time tend to be very mild, there hasn't been a lot of work done on antivirals or vaccines because it didn't seem like it was all that important. But this is just a little bit of data. You heard that we are running something called CATCH, the virus study. It's called Characterizing and Tracking College Health. And we have enrolled hundreds of students over the last several years. And you can see that these lists of CoV229E and HKU1 and so forth are the common cold viruses. There are a lot of other common cold viruses too, but these are around all the time. And 17% of people have had these common coronaviruses in our cohort over the 3 years that we've been studying. You can also see, for comparison, that we see influenza every year too on campus, different viruses each year, and about 10% of the people we followed had influenza virus. This year we're seeing some influenza, we're seeing coronaviruses like the OC43, and we're seeing lots and lots of rhinovirus. But we pay a lot of attention to influenza, and we're going to keep coming back to influenza here because it is the common killer. Hundreds of thousands of people die of influenza every year across the planet. The case fatality rate is around 1/10%. 75% of the infected, though, are asymptomatic. So that 1/10% is really probably a little bit of an overestimate. The deaths in the United States run between 12 and 56,000 people every year. Some years more. In fact, a couple of years ago, we had about 60,000 people died of influenza. Many hundreds of thousands are hospitalized every year, and huge proportions of the population are infected but don't even know it. Meanwhile, COVID-19, this new emerging infection, has, by comparison, infected hardly anybody yet and has caused a paltry number of deaths. Not that any death is insignificant, but by comparison to the hundreds of thousands that will die of influenza this year, the 2,000 died so far from coronavirus is pretty small. So we're going to be talking a lot about, as you will hear later, about why does this stimulate so much concern. And part of it is because although the deaths have been small, the numbers of people infected have been fairly small, and so the death rate, the case fatality rate so far, as we know right now, has been fairly high, but we don't know the full scope of that. We don't really know how many people were infected yet. But meanwhile, in the context, while all this is going on over in China, there's been practically none here, 15 cases, but there's been a lot of influenza here this year. And you can see in this plot, which shows on the left the number, the percent of people who are coming to see doctors for influenza-like illness each year. In 2009, the 2009 pandemic, there were a lot of people coming to see doctors for flu. But you can also see that in 2017-18, it was nearly the same numbers. It was just shifted later in the year. And this year is en route to be a pretty bad year too. And that's happening here and now. And you can see over on the other side the plot of pediatric deaths of young children dying of influenza. And so far this year, we've had 92 children die of influenza. A couple of years ago, we had 188. So this is what we are really confronting right now. So what can you do to stay safe? Well, I hope you got the flu shot. The flu shot is the most important thing you can do. It's not 100%, but it does make a difference. And then you can wash your hands, cover your coughs, dispose of tissues, avoid crowds, stay home. Avoid close proximity with someone who's ill, and avoid places that have poor ventilation. And we'll come back in a minute to why I think that is also an important recommendation. So, what is this new coronavirus? What are the symptoms? The COVID-19 mostly presents with people with having fever and respiratory symptoms, mostly dry cough, sometimes a little bit of productive cough with some sputum, a lot of fatigue, muscle aches. So most of these symptoms are pretty much indistinguishable from influenza. But COVID-19 probably has more GI symptoms than, but even though they're still a fairly small proportion of the population, it can infect the GI tract. And so that is becoming important to understand. So one of the ways that actually it's being diagnosed now, especially when healthcare is overwhelmed and there are not enough, test kits, is to look at the chest x-ray and especially the CT scan. And these figures up here are pictures of CT scans. With the top row, you see, compared with the bottom row, you see a lot of white stuff in the lungs. That's pneumonia. And people are presenting with pneumonia as a key part of their presentation, as we say. It's one of the first things that shows up clinically on a medical exam. So this is a family tree or phylogeny of the coronaviruses. And the ones with the picture of the woman coughing are pointing to those four that I said are the common coronaviruses that are around all the time, that you all have had them before. And the other three, the SARS-CoV is the one that emerged in 2003, the MERS-CoV, or Middle East Respiratory Syndrome virus, emerged in 2012, and the SARS-CoV-2 emerged last December. And this new virus is called a beta coronavirus. In those last slides, you see the blue things. Those are the beta coronaviruses. And at first, it was clear that it was a beta coronavirus. It fell in that family tree. And then as more data came along, it became quickly apparent that the closest viruses that people had isolated before in that family tree were in bats. But SARS came from bats too, but it didn't come directly from bats. It came from bats through civet cats. And here we think the best data so far suggests that maybe, but we're not quite sure yet, that it got from the bats through the pangolins. possible bridging species. And there's a picture of a pangolin. I never heard of a pangolin before either, so it looks like a cute little animal, but it's an insect eater. It loves termites. Hope I don't need one in my house. And by looking at time here on the x-axis and mutations on the y-axis, and there have only been 7 or 8 mutations identified so far, we see that you can trace this back in time. And this is part of the evidence that it emerged in around December of 2019 in Wuhan. So how is it transmitted? How does it move from person to person? Well, this graph comes from an article in the New England Journal from about 2 weeks ago, looking at what happened at a business meeting in Germany. There was a businesswoman from Shanghai who came to visit and met with some people in Germany, and she infected a couple of people at that business meeting, patients 1 and 2 from Germany. And initially it was reported that her symptoms appeared later, but it turns out actually that she had symptoms while she was in Germany. She was taking some Tylenol or ibuprofen or something during that meeting. She felt achy and tired. And so she was transmitting while symptomatic. But case number 1 didn't develop symptoms for another 4 days, yet he apparently infected 2 other people who did not have contact with the businesswoman from Shanghai before he got symptoms. One of them, patient 3, practically the same time he was getting infected. So there's pretty clear evidence that transmission can happen before people start feeling sick. Now, that makes this pretty different than a lot of other things. One of the things about the 2003 SARS outbreak was that people were not very infectious at all, if at all, until they got pretty sick. And a lot of the transmission actually happened in healthcare facilities before the proper infection controls got instituted. And in the United States, we didn't see much transmission at all, partly because our hospitals did a good job on that. 1 or 2 cases that came here. But we have to think about how this transmits and what you can do to be protected. Now, the modes of transmission of viruses, we know mostly what we know, it comes from studies of influenza virus. So we're coming back to a good old influenza virus again. Most of the studies are of influenza because that's the big killer. And we have to study this. This is what we do here at the School of Public Health with the Gesundheit machine. And we have found that people shed influenza virus before, without even coughing. Even though they're sick, they're not coughing. And so the modes of transmission can be airborne, can be large droplet spray. They can be also, we're learning now, fecal oral, because this virus, the COVID-19 virus, infects the GI tract. And so we're having to pay attention to that too. So how do you clean up and disinfect? Well, you can look at the label. If it's got enough ethanol, enough alcohol in it, or it's got a lot of hydrogen peroxide, or household bleach at 10% bleach, which is 1/10%, that works. The take-home message is wash your hands, cover your coughs, avoid crowds. Don't be present when you're sick. Presenteeism is a big problem. Stay home, don't infect other people. Avoid close contact with sick people, and avoid sharing poorly ventilated spaces. Turn on the fresh air in your car. So that is a description about the coronavirus and something about transmission. Next, we're going to talk about the epidemiology, how it spread fast in China and not so fast elsewhere. And Dr. Anji Liu is going to tell you about that. Thank you.
Thank you, Dr. Don Milton. I have closely monitored the new epidemic of COVID-19 because I have family members in China. However, the longer I observed, the less worried for my family members. You will see why. I'm going to first briefly present the features of the new epidemic of COVID-19, followed with my answer to this question: why has it fast spread in China but not in other countries? This is the scope of the epidemic. By February 16, a total of 51,857 cases has been reported worldwide. And you can see that these two numbers are very close, which means that the global epidemic of coronavirus is largely determined by the epidemic in China. Now, beside of China, 25 countries reported a total of 603 cases, including 3 deaths. Something wrong here? Can someone help me? Okay. What's happened? I want to go back. You see?
It's not going back, so.
Okay, sorry about that. Now, the epidemic starts in Wuhan. Wuhan is the capital city of Hubei province. By the end of last year, a total of 89 cases were reported in the city of Wuhan. And in the following 20 days, the epidemic fast spread all over the provinces in China. You can see the number of cases dramatically increased at the different wave of the epidemic. Now, there are 2 curves here. The first curve displays the distribution of patients according to their date of symptom onset. The epidemic reached peak at this point on January 25 to January 29th. Now, there is a second curve, which is this curve. This curve displays the number of cases based upon their data report. Now, pay attention here. There is a lag period between these 2 curves. This lag period had facilitated the fast spread of the epidemic in China, because during this period, patients still remain in the community. They still transmit virus. They have not been isolated. They have not been treated. Consequently, the chance to expose to these cases are huge. Consequently, we see the rapid spread of the epidemic in China. This is the distribution of cases outside of China. And majority of the cases reported from other countries had direct or indirect contact with patients in Wuhan or other cities in China. The very few cases had transmitted virus to others. Therefore, so far, we haven't seen an outbreak outside China except one. The Diamond Princess cruise has the largest outbreak of the coronavirus in the cruise ship. By far, 70% of passengers have been infected. That's totally due to the failure of quarantine on the cruise ship. Now, these two tables are pretty busy. Let me summarize here. The majority of cases were Hubei residents and who had travel history to Wuhan. I want you guys pay attention to the severity of symptoms. Most of the cases had mild or moderate symptoms. About 5% of the cases had extreme severe symptoms. For example, the failure of lung function or failure of heart function. However, the deaths only occur among patients with extreme severe symptoms, not among these two groups of people. And also, the mortality is higher among old patients who were 80 years old or older, and among cases with coexisting diseases. There are two terms you often heard in an epidemic. One is reproductive number, the other one is fatality. The basic reproductive number measures the speed of an epidemic, also measures the scope of epidemic. The fatality measures the severity of epidemic, meaning what proportion of the cases who died of the disease. So if RU equals 2, meaning if I was patient, I have a chance to transmit the virus to the other two. So the epidemic continues as long as R0 is greater than 1. The epidemic could be end when R0 less than 1. I compare the two indexes across the three respiratory diseases. You can see that the mortality of COVID-19 is 2.3. However, the fatality in China is largely determined by the fatality in Hubei province. Now, outside Hubei province, the mortality was only 0.4, and similar mortality can be seen from cases reported from other countries. Now, look at SARS in China. In 2002 and 2003, the mortality was 9.1, which is huge, much higher than COVID-19. Now, if you look at the influenza, during this influenza season in the United States, about 45 million flu cases. Among them, 6,100 died, leading to a mortality of 0.03%. Now, if we estimate mortality among hospitalized influenza patients, the fatality is 7.5, which is also higher than COVID-19. So you can see that the fatality rate of COVID is less than SARS, but similar to influenza. Now, you look at the value of R0. The value of R0 are very similar among three diseases, which tell us that the scope of COVID virus or COVID disease and the speed of the epidemic is similar to the other two, to SARS and influenza. However, the mortality of COVID-19 is smaller than SARS, similar to influenza. We see influenza cases every day. Therefore, I'm not quite worried about my family members in China. Now, why is the epidemic spread so fast in China but not in other countries so far? That's because China missed very important prevention opportunities. Before January 1st, the epidemic was localized in the city of Wuhan, a total of 83 reported. If the intervention action were taken on January 4th or before that, the spread of virus from Wuhan to other areas in China could be prevented and the epidemic could be reduced or localized in the city of Wuhan. However, there was no effective actions until January 20th. It's too late. At that point, a lot of cases exist in our community, continue to spread virus to others. Now, 3 days later, the city of Wuhan was shut down. At that point, when Wuhan was shut down, the virus had been spread to other provinces already. It's too late. And Wuhan is located in the center of China, which is also the transportation hub. Before January 26, 5 million people left Wuhan. At that time, it was Chinese first season, Spring Festival season, which is equivalent to Christmas season in the United States. People return to home for family reunions. They bring food, money to their family members, but also bring virus to their hometown. And also pay attention to the 9 million residents still remain in Wuhan. They had high risk to be infected by this number of cases still exist in Wuhan. Consequently, you see the outbreak exists in Wuhan and in other areas in China. Now, the epidemic can be prevented simply by use the traditional public health measures we call 3E. Early identify infected individuals, early treat patients, early quarantine, and close contacts for 14 days. 14 days is one incubation period. And 3 interventions have been successfully implemented in other countries. For example, in the United States, even though we have about 20 or 30 imported cases, there is no outbreak in the United States so far. And China missed the opportunity to uptake 3 interventions. Consequently, we see the fast spread of the virus and fast spread of the epidemic in China. This is end of my presentation. Our next speaker is Dr. Cynthia Bao. Dr. Cynthia Bao is an endowed professor and director for Hollywood Center for Health Literacy.
Great. Well, hello, thank you, and good afternoon. So as you've heard from my 2 colleagues, from Dr. Milton and Dr. Liu, we have the data on what is going on with this particular viral situation. So if we were all perfectly rational and living in the United States, we would look at the data and we would conclude what the public health experts have concluded is that our personal risk is low right now living in the United States. But we are not perfectly rational beings. We are affected by the things that we see, the things that we hear, what other people share with us. And so that's what we're going to talk about now for a few minutes, is what's going on in terms of the communication, the information exposure that we have had, and why some people may be feeling anxious or concerned or worried. And my job is to show you that if effective risk communication is doing its job, it should actually leave you more confident and more informed and better prepared to take care of yourself. So right now, we are in a situation not only of potentially ineffective control of the virus in certain locations, but we've got ineffective risk communication going on because the anxiety and the worry should be appropriately adjusted to the data that we have. So are you more likely to die today because of a distracted driver or coronavirus? And the answer to that question is, it depends. It depends on the kinds of things that my colleagues just explained to you. Because if you're here, it's probably a distracted driver. But if you're someplace else, under the conditions that you just heard about, it might indeed be the coronavirus. So this is a very classic way of thinking about why people get concerned about different kinds of risks. Because we react to situations in terms of how much dread we feel about them and how much uncertainty there is about that situation. And so you can see that we can plot people's dread and uncertainty in each of these different quadrants. And so our reaction to the situation is going to reflect the intersection of those two factors. So while some people can be very worried and concerned about a situation, other people can go about their daily business, their normal lives, and not be worried about that same piece of information. So you can see what we're really just dealing with here is perception, right? And we know that perception informs our feelings, our thoughts, and eventually our actions. So we want to take a closer look at some of these things that are affecting our perceptions. So one of them is this image. This image is supposed to be conveying something to you. And while it's very attractive, it's very colorful, its information value is actually pretty low because it tells you absolutely nothing about the coronavirus and what your personal risk might be. This is another set of images that we're seeing a lot of. We're seeing people in this very protective gear, suited up, covered up. So we've got an emergency chopper in the background. Those are the kinds of images that may raise our feelings of anxiety and worry because we know that those things are associated with danger. People only put on that kind of personal protective equipment and use medical choppers when there's a very serious situation. Empty roads. How many times do you see a perfectly empty freeway? Rarely, if ever. So again, it's a symbol that somehow something different, something unusual is going on. So again, even though our personal risk here may be low, we're seeing these images and thinking, oh, well, if it could happen there, why wouldn't it happen here? Uncertainty. As I showed you in that grid, the level of uncertainty and dread that we have interact with each other, and the more uncertain we feel, the more anxious we're going to feel. And as I said, if the risk communication is working in the way that it's supposed to, we should be feeling more confident, more secure in understanding what our personal risk is so that we can take appropriate actions. Another set of images that we're seeing, again, people in that protective gear, but one of the things that is also complicating this situation is the type of information coming from the epicenter of the outbreak. Is that the information, as Dr. Liu said, the information has been slow, it's been incomplete, we don't always have a good picture of what's going on in the actual location where the disease is most severe. So this is, again, complicating the situation and adding to our uncertainty because if we can't trust the source, then that feeds our uncertainty. And finally, we know that there's a lot of information sharing going on. In a minute, we're going to take a look at what some of this disinformation is. And you can ask about people's motivation. Why are they sharing this misinformation? People can have a lot of different motives. There can be political motives, economic motives. People can just be innocently sharing things because they think it's of value, but misunderstand that it could start inciting a lot of concern and panic. But this information sharing through particularly social media is really helping fuel a lot of the ineffective risk communication. So if you want to find out what's really going on, there are places that you might naturally think about going. So you heard from Dr. Kleiman. I used to work at the Centers for Disease Control and Prevention in Atlanta, Georgia. And when I do talks with students, a lot of times when I ask them, where do you go for information, they'll say, I go to CDC, or I go to the National Institutes of Health, or the Food and Drug Administration. Well, so I went to CDC to see what they were saying about coronavirus, and this was the first Q&A that they had under disease basics, and it says, what is novel coronavirus? A novel coronavirus is a new coronavirus. Well, novel and new are exactly the same thing that has not been previously identified. And then it goes into this description, as you heard, that is like the common cold, but then you get all of this very technical scientific information about the virus. So if I'm just a member of the public without any particular medical or scientific background, and I go looking for a plain language explanation of what the disease is, Unfortunately, I'm not going to find it here. And I also checked other credible sources like the World Health Organization and NIH, and I also could not find plain language explanations of what coronavirus is. So when we go to credible sources and we don't find things we understand, what we do, very logically, is we start to fill in with what we do know. And we are finding out that people are filling in with some very inaccurate information. So when we started looking for what kinds of disinformation are out there, we found these kinds of things. So for example, somebody's putting out there that FEMA's imposing martial law, that people are abandoning their kids in airports, that there's 112,000 people dead, that all of these cases are showing up in American cities, right? So the disinformation is of a wide variety and being very actively spread. And this is, again, fueling all of that uncertainty. So the social media platforms, the search engines, they are trying to scramble, as the headline says, to kind of figure out how to stop all of this misinformation. But we know that people are still sharing a lot of it. So this information environment that we're in continues to feed people's anxiety and uncertainty. So these are some of the consequences that we're starting to see. We are seeing fear, we are seeing anxiety, we are seeing bias and stereotyping, and in fact, we found out just before we started this symposium that the UMD Office of Diversity and Inclusion had put out a statement to help people understand how their fears and anxieties could be contributing to racism and scapegoating. So I would encourage you to take a look at some of those tips, because really it's inappropriately causing a lot of problems by stigmatizing certain groups of people and also causing anxiety, unnecessary anxiety for yourselves. We also are seeing that people are looking to fake or harmful remedies. So there can be actual, real physical consequences if you start trying things that could cause you more harm than good. So again, you think, well, it's just information, right? I just saying things. Well, I saw something and, what's the harm in sharing that? Well, people will potentially take action on those things that you're sharing. So I would strongly encourage you to think carefully about what's the real evidence base of that information that you have, and have you actually confirmed it with the kinds of evidence and data that you saw in the earlier presentation. So I'm going to give you a personal to-do list, right? So for everyone here, everyone watching us, everyone who might watch the recording afterwards, I want to encourage you to think about, we're talking about people here. And that will, if you do that, that will help keep you grounded in the sense that we need to have empathy by those who are truly affected. And that will keep this to, at the human-centered situation, right? It maybe will cause you to stop and think, should I be sharing this information? Or should I be saying that thing? Or should I be, thinking this about this particular group of people? Because empathy really says, there are people here, I need to think about what are the consequences of what I'm saying and doing. I would encourage you to just adjust your expectations and assume that we are going to keep learning more. So good risk communication sets you up to understand that we're always learning something new. So what we know today is not what we will know tomorrow about the virus. So expect that you will keep hearing new information. Follow the kinds of precautions that you heard my colleagues talk about and that we'll put back up at the end of this presentation. Wash your hands, cover your cough, do those things that we know are good for infection control. I want to encourage you to always test your assumptions about what the nature of the risk is and whether you're really getting credible data to make that decision. Don't just assume that because your friend shared it with you, or you saw it on a social media platform, or you read it on the internet, which is what I hear a lot of times, that that makes it true. Really test out those assumptions and make sure that you have a good, credible, verifiable source of information. I would encourage you to be a disruptor, and a disruptor in a positive way. Disrupt disinformation. Stop that supply and demand. Make sure you are being a positive force in the information environment. And finally, I would encourage you to take a break from constant news updates. Give your mind a rest. It will help give you some perspective on what the nature of this situation is, and it will help you conclude in an appropriate way what your personal level of risk is. So thank you very much, and I'm going to hand it off to our last speaker, Boris Lushniak, who will wrap us up.
Thank you so much, Cynthia, and thank you all for being here today, and for our viewers and those watching this tape. I hope thus far this has provided some information for you. My job right now is to sort of wrap this up, right? Prior to our Q's and A's after all this, in which case we'll all be sitting here answering your specific questions or those sent in via the various streaming methodologies out there. And I'm here really to share kind of the optimism approach. As you heard from the kind intro that you had, is I've been here as dean for the last 3 years in the School of Public Health. Prior to that was 28 years in federal service. So I'm a public health practitioner. And during that time, 27 of those years as a uniformed officer in the United States Public Health Commission Corps, in essence is I've been blessed or cursed with the idea of having been a responder to multiple events in that time period. World Trade Center, the anthrax attacks, Hurricane Katrina, Ebola, and yes, the 2009 pandemic of influenza. And in these next 10 minutes, what I'm going to emphasize is we may not have all the answers. And I'm not going to say that no matter what happens, everything is going to work out just fine. But in essence, the optimism is what? The optimism is there has been a system already tested. And the system that if this goes in a direction that we're not expecting at this point, that in essence is public health is ready to respond. May not be perfect. And that response occurs where? It occurs at the local level. What's happening here on this campus, that's local level response. Working with student health, working with student affairs, working with our communications and our response teams on this campus. It spreads into the county level, it spreads into the state level, into region level, national level, and yes, international levels of response. This is my optimism slide as a public health person. This has been on my office wall since 1999. Right? Whenever I think, we're not really doing that well, I'll look back at this, and these are the 10 accomplishments of public health as listed by the Centers for Disease Control and Prevention, my former employer as well. And on that list, notice that control of infectious diseases was a major accomplishment in the 20th century. Between the year 1900 and 1999, if you look back historically, what took place? We started in the year 1900 with no vaccines available. We didn't have antiviral medications. We didn't have antibacterial medications, right? We didn't have diagnostics. So the idea of how science and public health worked together in the course of that century, it didn't eliminate infectious diseases, but certainly we had a better sense of what's going on in the human body, our immune system, in these other interactions of having the therapeutics and the diagnostics and other things out there to help us in this approach. As already mentioned, most of our experience in the world of infectious diseases, when it really hits big populations, is with seasonal influenza. And I'll remind you yet again, right? This is an annual respiratory illness. We're in the midst of flu season right now. This happens every year. We have worse years and we have better years. The impact globally, up to 500,000 people die every year from influenza across the world. Does it necessarily make the news each and every day? Well, when the news sort of picks it up, right? When the news says we have an angle to it, then it's on the news. Otherwise, it's almost taken as if it's a given. We have the flu season. Perhaps up to a fifth of the US population can at times have the illness during flu season. We can see the range of deaths, right? Is it 36,000? Is it 50,000? Right now, I think we're around 14,000 people have died in the United States this flu season. And of course, its repercussions in our society, sometimes measured as economic costs, but this is a major issue in terms of the economy, in terms of impacting our society. The reason I bring up flu is that oftentimes, we sometimes neglect this idea of seasonal flu, which is an annual event, and we get it confused with another term. And you're going to hear this term a lot. We're already talking about it. Notice we were very precise in our terminology, in our lexicon, in the words we're using. We call it the current COVID-19 situation as an outbreak. We call it an epidemic, but we don't use the P word. Right? It's out there. Talk about, ooh, is this going to be a pandemic? Well, what's the definition of a pandemic? World Health Organization, the world body dealing with health issues, part of the United Nations describes it as an epidemic occurring worldwide, as opposed to regionally, as opposed within one jurisdiction, crosses international boundaries, and usually affects a lot of people. Right? That's a pandemic. Right? And pandemics are always kind of scary to us. It's like, oh my God, this is spreading. This is gonna, gonna wipe us out. This is, it's the essence of a board game, right? Who's played the game Pandemic? It's now on video and all this, where you play the role of an infectious disease, right? But in essence, it is potentially a problem. And it is something that may evolve out of this. In the next days, weeks, perhaps months, we'll see if this COVID-19 becomes an issue and becomes a pandemic or not. Because in essence, part of the formula is already there, as listed here. Is it a new subtype of virus? It's not an influenza virus, it's a coronavirus, but it's a new subtype and one that our bodies have not seen before. So that's of concern here with COVID. It's a virus that produces serious illness, and the virus must be able to be spread efficiently from one person to another. Those are the major parameters of a pandemic occurring. Now, when we talk about pandemic in the 20th century and now in the 21st century, these are our examples of what has taken place. And once again, I emphasize, this isn't coronavirus examples historically, this is influenza virus. 100 years ago, 1918, 1919, something we called the Spanish flu was a major killer. Mind you, it was early in the 20th century, before a lot of advances in public health, before a lot of advances in medicine. This was a major killer. Perhaps 40 to 50 million people died worldwide in those years during the Spanish flu. 57 to 58, we had another pandemic of influenza. 68 to 69 was a third pandemic at that point. And ultimately, the latest one, just 10 short years ago, was the pandemic of 2009, an organism called H1N1. And although I was part of the US government at that point, and we were monitoring what's going on, and in essence, what's interesting is we were monitoring what was going on in China. We were looking at a whole other organism called H5N1. And we're monitoring, looking, where is it going to happen? Is it going to happen? This is the potential pandemic. And just shows you sort of the beauty of the world of viruses, of these organisms, because in essence this was kind of a sucker punch. It was a sucker punch because it didn't start in China, it started in the United States. It started in our own backyard, and it ultimately spread to the world from here. You can see the impact of that 2009 epidemic or pandemic as listed here. Why are we so worried about pandemics? Well, things were bad at the early start of the 20th century with the Spanish flu. But you can imagine how life has changed in these 100+ years now, right? The global population is larger and it's more urbanized. What does that mean? It means we're living closer together. Right? The ability of spreading disease from one person to another happens because of the environment we're in. Second aspect in the 21st century, certainly we're traveling a whole lot more. Right? It's uncanny. These aren't 1 billion people, these are 1 billion passengers. So in that sense, if I travel 7 times a year, I'm counted 7 times. But in the United States, this is domestic flights and international flights. In our nation alone, we have 1 billion passengers moving into 2018. 1 billion people that are moving around, which means what? It's not like the old days where I'm just sitting in my house and, I go down to the store and I walk. No, we can spread disease very easily. And certainly the demographics have changed in our society. Elderly population has increased and those with chronic conditions have increased, which means the whole idea of susceptible people. Right? People who are living okay, but perhaps the immune system may be a little off. Perhaps there'll be higher susceptibility with potential diseases. My last few slides are going to be kind of busy, but the key feature of these slides are what? This is what occurred 10 years ago, and I want you especially to pay attention to a timeline, because this is the optimism slide, right? Remember what I said. We're looking at China for H5N1. What happens? April 15, 2009. I'll remember that day as if it was yesterday, because I'm in charge of counterterrorism and emerging threats at the Food and Drug Administration, right? So we've been monitoring all this, right? What happens? April 15th, we're told through the CDC This is a few days afterwards. There was a case confirmed a few days ago in California in a 10-year-old boy through a clinical lab study that we have a very unique virus. We have a novel virus. We've not seen this one before. Okay, so we're now ramped up a little bit. 2 days later, there's a second case. Now we're actually very worried. Mind you, there's only 2 cases, but this is 130 miles away, and in essence, it's the same organism, which means it's probably been out there, maybe asymptomatic, maybe already being spread, but we're picking up 2. By April 21st, there's already work on the candidate vaccine. Science has changed. And granted, this is influenza. We're already making vaccines every year, but all of a sudden, we're shifting into another mode with 2 cases. CDC starts activating its Emergency Operations Center. There's 2 more cases in Texas. We're getting case reports from Mexico and Canada. FDA, where I'm working at, has its Emergency Operations Center. By the 25th of April, WHO declares a public health emergency of international concern. What does that mean? Same thing that's going on with COVID-19 now. An extraordinary event constitutes a public health risk through international spread to potentially require a coordinated international response. By the 25th of 2009, we have a cluster in New York City. We have cases in Kansas and Ohio. The United States government declares a public health emergency and implements the National Pandemic Response Plan. Part of that is a strategic national stockpile. Medicines and equipment that's stationed throughout the United States is now moving. Notice how quickly. This is 10 days after the first case. By April 27, WHO says, yeah, there may be a pandemic happening. It's something called phase 4, human-to-human spread, and there's community-level outbreaks. By April 28th, we have a diagnostic that's cleared by FDA, so we have ability to diagnose this under something called emergency use authorization, which allows products that have just come on board to be let out there. WHO pandemic alert level goes to phase 5, human to spread in 2 nations in 1 region. That means a pandemic is imminent. By June 11th, it's a full-fledged pandemic. It's phase 6. Pandemic, community-level outbreaks in at least 1 nation in a different region of the world. We now have 70 nations affected by this influenza. By June 19th, all 50 states, D.C., Puerto Rico, U.S. Virgin Islands are affected. By July 6th, we have 122 countries reporting over 94,000 cases. In the United States, we have 33,000 cases. By July, we stopped counting cases because over 1 million people are affected. You can see this growth. And yet there's already been a response so that we're starting clinical trials with a new vaccine by July 23rd. We have an approach with that vaccine. Vaccine's still not made fully, right? But we're talking about certain target groups for vaccination, right? Pregnant women, caretakers of infants, healthcare workers, young people. By September 15th, FDA licenses 4 vaccines. A 5th is added on November 16th. States get the vaccine. Doses are administered. By October, we have the peak of activity, the launch of a vaccination campaign. By November and December, enough of the vaccine that we're easing the restrictions on its distribution, and we're getting safety information back from that vaccine trial. So what we saw in 2009 was 2 waves, a peak in June and October. Hospitalization rates were highest in children, 0 to 4, and in working adults. Ultimately, we estimated over 60 million people in the United States had that influenza. We were kind of blessed in that it was a mild pandemic. It was a true pandemic. Death-wise, we're a little over 12,000, perhaps 500,000 worldwide. Higher level of disease in young people from that pandemic, and ultimately was declared over by August 10th, 2010. So in conclusion, what were the successes from 2009? The 4 major pillars that we rely on in public health. One is surveillance, which is we got to be looking out there on what's going on. What's happening? Who's sick? Are they spreading it? Are people severely ill? Are they dying? The whole idea of working with our communities, right? This concept of community mitigation, right? A term called non-pharmaceutical intervention, which goes back to a common message we've all been talking about through our presentations. Stay at home when you're sick. You cover your cough and sneezes. Real young kids have it down. They're taught right off the bat. You're going to cough or sneeze, what do? You do it into your elbow, not into your hand. Frequent hand washing. cleaning of touch surfaces and objects, and reducing social contacts during these types of times of illness. Vaccine delivery played a key role in 2009, as did communication. So, as we prepare ourselves for what potentially is going to happen with coronavirus, again, it's unclear. Are we heading towards a pandemic? I don't know. But ultimately, much like the Department of Health and Human Services has warned us all along, whether it was the Spanish flu in 1918 or our preparations for the next pandemic, pandemics have the potential to be major problems for us, for our society, for our people, for the worldwide community. And at the same time, we've learned a lot over the years. Right? Are we filled with hubris saying, oh my God, we can handle this? Well, we're not cocky about this, but we're pretty darn good. So thank you so much for your attention. And now we're going to set up our time for the questions and answers.
Thank you very much. And thank you to all our speakers when we give them all a hand again. We have set up 2 mics, one on either side of the stage. And you can line up if you would like to ask a question. I'll go from one side to the other. We also have been receiving questions from our online audience as well. I will start with one question that we have been given, and then we will see if there's others. Do not be shy. Any question is a valuable question at this stage, and so please do. I can see some of our wonderful students in the audience, our faculty, our community members. We appreciate your coming here, and we value your questions. So the first question that people have been asking is, when will there be a vaccine to prevent infection by this particular virus? And I was going to ask Dr. Milton to answer that.
There's a lot of work now underway. There are some candidates that have been produced, but it takes a while to get something through animal testing, safety, and into human trials. So it's going to be a while, perhaps as much as a year, before we have a vaccine available.
Thank you, Don.
Right, I'll put my 2 cents into that as well, having been formerly at the Food and Drug Administration. You know, as Don has stated, part of it is that Food and Drug Administration has incredible authority, right? But its ultimate goal is what? Is to make sure things are safe. That's rule number 1. And then secondly, is make sure they work. So as these candidate vaccines are being looked at, nothing's released to the public until safety studies have been done, right? Those will be small numbers of people that are given the vaccine, volunteers, right? That in essence, people say, I'm giving you the vaccine, we're going to monitor how things are going. That takes a while. But the incredible authority that the Food and Drug Administration does have with emergency use authorization allows the product to go out there before it's actually fully tested in terms of whether it works or not. It's never released unless it's deemed safe. But in essence, if things really get bad, there is this potential of releasing products earlier before all the studies have come in. And in essence, the studies go on as part of the pandemic or epidemic or outbreak. So in essence, those are relatively new rules that were started in the post-9/11 era. But I agree with Don. I think, you know, a year is sort of the time period that we're all sort of saying in terms of a potential vaccine.
It'll take longer than just getting a new flu vaccine did in 2009, because we already had a lot of flu vaccines and it was just a little tweak to the flu vaccine. This is like a major thing to come up with a vaccine for a virus that we don't have any vaccines for any related virus at this point.
Yeah, I want to add something.
Okay. Can we go on to the next question and continue on? Please.
Hi, this is, I guess, more of like a surveillance about the mortality. Dr. Liu, one of your slides showed the number of deaths, and you sort of indicated that the percentage was mostly those over, like elderly adults and those with other conditions. Are we seeing anything yet showing that this might be targeting a healthier population like we saw with the 2009 influenza outbreak?
Well, that's a good question. The virus has been spread to medical care workers, especially physicians who take care of patients. However, this transmission occur in a special situation because there is close contact between physician and patients. Therefore, the intensity of the exposure between patients and doctors is huge. Consequently, we see some doctors are also infected by the virus. However, so far, we haven't seen any so-called super spreader in hospitals. Did I answer your question? Did I answer your question?
I was sort of curious to know, is it, like, I think with 2009, with the swine flu, like, you were getting, like, healthy adults, and that was, like, a lot of the mortality
Right.
was among them. Besides the spread to, like, health workers, are we seeing anything of that now, or is the mortality still among, like, older adults and immunochallenged?
Yeah, based on the surveillance data from China, the majority of deaths come from older patients for still 60, 70. There's good news. Based upon, my former student who is a chief epidemiologist in China CDC, based on their observation, the virus is muted. The attack rate of the virus has been reduced in China.
You know, it is interesting from that perspective of also the sort of the uncertainty of these viruses, right? And in essence, it's very perceptive of you to sort of pick up on this idea, the difference between 2009 and perhaps any other data that goes on. 2009 really took us by surprise. And part of the explanation may have been that although H1N1 was a novel, brand new virus, there was a similar virus like in the 60s and 70s. And the sense was maybe the older population had at least some tweak of immunity. The body remembered that old virus that had enough similarities. So the severe cases really were in the working adults and younger population that never had exposure to that, a virus, similar virus in the 70s.
Yes, please.
Hi, I came in a bit late, so apologies if you covered this. I have two questions. One is, what's known right now about potential alternative transmission modes? I know there have been some reports in the news about possibly the virus being spread in feces as well. And so what's known about that currently? And then second is a question about sort of the preparedness and the list of, I know, vaccine development is right up there, but what kind of formal procedures are there to really study transmission modes and latent periods in these kinds of outbreaks? Because that seems incredibly important for managing response.
Yeah, so there's
John,
increasing...
could you sort of repeat the question as well?
So the question was about modes of transmission, and particularly our feces containing virus. So is there a fecal-oral transmission mode? The second part was about how are we studying transmission? So yes, so there's increasing reports that it's known that the way the virus attaches to cells is through something that's present in the lungs, but also present in the gut, so that it can infect the gut. And although most of the infections have been through the respiratory tract, there have been some through the gut. And there were, for example, there was a hospital outbreak where a patient was admitted with abdominal symptoms to a surgical service and infected other people in that surgical service, and they got abdominal symptoms. So it suggests that if you get a fecal-oral transmission, it's probably going to turn up with abdominal symptoms, diarrhea. Whereas if you get it into your lungs, you're likely going to get respiratory. And so it can be transmitted that way. It's not clear that very much has been transmitted through the fecal-oral route, that it's mostly been through the respiratory route. a lot of what's being done now is looking at case histories and trying to understand what's happened in households. But there also are a number of efforts out there now to try and collect air samples in hospitals and other places where there may be cases to try to understand, is it present in the air, just from the air. And there's a lot of work going on in several countries now, in Singapore and in China and Hong Kong, trying to work on that.
Thank you, Don. We're going to take 2 more questions. I'll start at the right and then on the left.
Hi. I would like to know, I have 2 questions. One is, why is it 14 days that the quarantine lasts? And the second one is, why haven't we developed a universal vaccine that can eliminate all infection from all of the strains of influenza?
The first question was the 14 days. Why the 14 days?
The 14 days is based on the observation that people, if they hadn't gotten shown positive virus symptoms within 14 days, they didn't turn up later. So observations on a lot of people, and Dr. Liu may want to speak to that. And as far as the universal vaccine against all influenza viruses is concerned, there's a lot of work going on to that. NIH is putting out a number of requests for proposals. There's the problem with influenza is that it mutates rapidly, and so it changes from year to year. And just like these coronaviruses, the newly emerging coronaviruses, there are a lot of influenza viruses in wild birds, and they then gradually move sometimes into the human population. And when we see that often through pigs, and these new emerging viruses are really different than the ones we've had before. And so it's hard to come up with a way to make a vaccine that can cover this large landscape.
Okay, thank you, Don. Our last question.
Thank you. My name is Mengxue Li. I'm from Behavioral and Social Science School. Actually, my question is to pass some question. I have been asked by some international students, especially a Chinese student or Chinese American student, and even some faculty with Chinese background. Because by talking with them, many similar experienced, and I was told is that usually when they come to the campus, and then usually the most common 2 questions they will be asked is, did you go to China recently? Or have you been to Wuhan or Hubei province? So those kind of things, and then since they repeatedly been asked, and then people when they have this conversation, and people said, I understand, and people get worried, or there is anxiety about the virus, but how can I help people to divide the virus and a human being, and how can I explain myself, and how can I help others to remove their worries, so then I can feel comfortably be part of this event. Thank you.
Thank you so much for that very rich question. I'm going to ask Dr. Bauer to respond, but I think it's something for all of us to be thinking of, so we really appreciate it.
So I think, go back to a couple of things that we talked about. First of all, we would encourage everyone to retain a sense of empathy about this, and this is one of the things that was on the Office of Diversity Inclusion's checklist, was to remind the university community at large that they should cultivate a sense of empathy about this situation and remember that there are real consequences from expressing those kinds of attitudes about bias or stereotype. And the second thing would be to encourage people to go and get accurate information about what, in terms of like what was presented here today, what's on the university's web pages for this topic, other authoritative sources, and really be informed in terms of their understanding the nature of the risk. Because that's what we're trying to convey today, is that if you look at what the actual circumstances are, people here should have a very low sense of what the personal risk is. And so this is part of why this forum exists, is to inform and educate the university community. We hope that this will contribute to that effort to help people understand a little bit better about why they don't need to be quite so anxious or fearful.
I think we also should be aware, everybody should know, that the campus has been very proactive about trying to be aware of the situation and reach out to people. And I have been... My mic. People should be aware that the campus has been very proactive about trying to reach out to people who have been in China, and that I have been incredibly impressed with how seriously people, particularly people who were coming back to campus, who'd been in Wuhan, were about self-isolating and waiting the 14 days and being very careful about not exposing other people until they knew that they were safe. And I want to really take this opportunity to thank all of the people who did that from the bottom of my heart. I've just been really, really impressed. I think they've been really great. And thankfully, none of them were infected, and we're all safe.
You know, one of the things that I'm thinking of here as we're sitting here together, that we are all learners through this process. Whether we have learned lessons from before, we need to have fresh eyes with each new emergency, new event such as this one. And we're really fortunate to be here at the University of Maryland to learn from each other's, our other disciplines, but also from our personal experience and thoughts, and be able to share them candidly and openly. And so I want to take one more time to thank the panel, but then also ask Dean Loshniak to make a few closing comments. And thank you so much for your patience and for your presence.
Great. Thank you so much for moderating, Dashanka. Thank you for your attendance, those of you in the room here, and once again to the world out there in space, right, on the internet, on YouTube. You want to review this later on. This is going to be on the university's YouTube channel. We'll send out some information. It takes a community oftentimes to work together to get through difficult times. And we know at this university, I've been here for 3 years, and there's been a lot of difficult times for us to get through, right? There's been a lot of discussion. There's been a lot of sense of introspection of who we are as a community and how do we battle the next crisis, the next issue, right? What this university has proven to be in my short 3 years here is one of resilience and of ultimately of a community coming together and dealing with an issue. Now, again, none of us can predict where this is going to go as an infectious disease, right? We are impressed as a School of Public Health, a key component of this university community, of what's going on out there. The incredible work of student affairs, the incredible work of the health unit, the incredible work of communications, of all the entities, right, looking at this, right? This began during winter break. And during winter break, those of us who were here on campus realized we have to prepare. There's students coming back. Some are coming back from China. There's faculty people coming back. There's tourists coming back, right? And in essence, in a few short weeks, we're going to have the community back together again. And the key feature that we want to share with you is one that's critical. And I think Dr. Bauer made an important message here, which is, in essence, it's transparency. It's us sharing information, right, as a community. Now, we're not alone in this, right? If this really gets big, if it gets big, this is now not just the University of Maryland. We're part of the community of the state, of the county, of the nation, right? We then will get information from multiple sources. But ultimately, we also have a role in this community. One, to share the right information. So don't be, as already stated, a source of misinformation on this. right? You have questions, you ask us. We'll point you. You monitor the site here at umd.edu virus info. That is going to be updated all the time about any major changes here. Second aspect is you learned something today, we hope, something that we have to, even as public health professionals, remind ourselves. That oftentimes it ends up being the basics, that we don't necessarily have to wait for the vaccine or the antiviral or some agent that's going to assist us. That ultimately what we did in 1918, 1919 is actually applicable today, despite the science, despite the advances. It's great the science is there. It's great that we have the advances. But ultimately, one, take care of yourselves, right? Eat well. That's a public health message, but it plays a role, especially in the time of epidemics, right? Exercise, right? Moderation in everything, except exercise and eating well. But you know, the sense is take care of yourself. Take care of the people around you, right? Be concerned about your community, right? Be concerned about the psychosocial aspects. Health is about what? About physical, mental, and social well-being. That's what this community wants to be part of right now. And ultimately, if you do get ill, let people know about it. The health unit is here to help, right? Stay away from class. Let your professors know, those of you who are students, those of you who work here, let your supervisors know that you're not feeling well. And then ultimately, optimism. Right? Optimism. What's up here is important. And the sense is that we have potentially an issue in front of us. We have an issue that's taking place in China that may become an issue here. And one is of optimism, of us understanding how things are different in 2020 compared to past similar type issues. So we thank you so much for your attention. Thank you to my dear and beloved faculty who are presenting here today, to Dushanka Kleiman, also on the faculty of the School of Public Health, and thank you all. And now I do something that as the former acting Surgeon General of the United States, I used to do very often. Everybody raise your right hands. And you are now deputized as public health and information givers and members of the public health community. Go forth and spread the news about this disease. Thank you so much.